Gonioscopy made easy, taking the first step for glaucoma diagnosis. A 32-year-old male came to our OPD with previous diagnosis of juvenile glaucoma and was already on AGM. Fundus examination showed a cup disc ratio of 0.8 with inferior rim thinning. As a part of routine examination, we did gonioscopy, and yes, there was hidden a secret from the past. A 360-degree angle recession was noted, and our diagnosis changed. On detailed history, patient told he loved playing badminton in childhood and was hit in his eye while attempting a winning shot. This example clearly answers the question, why do we need gonioscopy? So, to guide diagnosis, to formulate treatment plan, to be well prepared for performing minimally invasive glaucoma surgery. The question is, are we doing enough gonioscopies? Chennai Glaucoma Study and APEDS gave an alarming result that 2/3 of PACG patients were being treated as primary open angle because gonio was not being performed or inadequately performed. Only 45% of patients had received gonioscopy within either 12 months prior or 6 months following the initial diagnosis of primary open angle glaucoma. So, what hampers us from performing gonioscopy? Limited training during residency, time consuming, difficult for patient and doctor in called OPD, subjective nature procedure with multiple classifications. If we look at AIGS and World Glaucoma Association consensus, they recommend gonioscopy as a must to complete an ophthalmic examination. Steps for perfect gonioscopy. Let's make it easy. Step 1. Keep your goal in mind. The gonioscopy exam is designed to identify proper angle structures in their natural position, including the iris insertion and any abnormal angle pathology. Aim to get the best possible view with minimum distortion. Check the lens surface for any scratch which can injure the cornea. A good communication skill is a key for any examination. Explain the procedure to the patient and put adequate anesthesia. Practice correct placement of lens. For 2 mirror, ask the patient to look up and gently place the lens. In case of 2 mirror, we need to rotate the lens by 90 degrees to have a complete angle view. For 4 mirror, gently place the lens and go ahead with exploring the angles. Make sure you place the lens on the center of the eye to have a perfect view. Avoid corneal folds as seen in this video. One easy way to identify a poorly centered lens is the appearance of air bubble under a portion of the lens that's not in the contact with cornea. Know your lenses. Goldman style lenses are easy to use with beautiful view and good for photo and laser, but they are inconvenient, cannot indent well, and time consuming in heavy OPD. Zeiss style lenses are convenient, easy to see the whole angle in one go, and are good for indentation gonioscopy, but they are harder to master and require corneal lens touch. Make a short thin beam for examining the angles. A small beam causes less pupil constriction and prevents a change in angle appearance. As seen in this video, as we enlarge the slit, subtle movement of iris are visible. Identify scleral spur, which is the brightest white line in the angle and serves as an important landmark. This video shows meeting of corneal wedge at shawl base line. After identifying and marking shawl base line, The sequence of angle structures from anterior to posterior are non-pigmented trabecular mesh, pigmented trabecular mesh, scleral spur, ciliary body band. Now, with the help of Schafer's grading, identify whether angle is open or closed. Make sure while making diagnosis, the eye is in primary position. Increased pigmentation can be suggestive of pigmentary or pseudo-explorative glaucoma. Peripheral anterior cyanicia should be well documented. This is a patient with neovascular glaucoma with 360-degree zipper angle closure. Neovascularization. A new vessel will be fine, arborizing and crossing the scleral spur, while a normal vessel will never cross the scleral spur. Blood in Scheimpf's, as seen in case of carotid cavernous fistula, Sturge-Weber syndrome, or even after heart gonioscopy. Here we can see the ostium performed during trabeculectomy. Here we can see tube of glaucoma drainage device. Foreign body arc angle as seen in the left side of stone and the right side an iron foreign body. Tails of vitreoretinal surgery can be seen in angles also, like silicone oil or even PFCL bubbles. These are some naughty haptics that refuse to stay in the bag. Violence, violence, violence. We hate violence, but we can't avoid violence-induced angle recession glaucoma, and yet even more violence causing cyclodialysis cleft. Over the field view, ask the patient to look towards the angle being viewed. Indentation gonioscopy. With 4-mirror gonial lens, gently indent cornea which opens the angle, thus helping in differentiating cynical angle closure from oppositional angle closure. Wait, don't hurry. Look at the complete angle as you can miss this silent creeper. To summarize, gonioscopy is an underrated and underutilized examination technique. Treasures are hidden away in angle, waiting to be found by those willing to pursue them.